Hello, everybody. This is TCTAP 2022 Structural Heart Disease Live Cases session for the TAVR. I'm Hong from the Severance Hospital. My co-moderator, everybody knows Dr. Makar from United States. We have the several distinguished panelists, Dr. Kao from Taiwan, from the and Dr. Rafael from Australia, and Dr. Santoso from Indonesia, and Dr. Ung, Hong Kong, China, and finally Dr. Yu from the Korea. Okay, first cases is the first moderator is Shea Park. Dr. Park, can you hear us?
Yes, I can hear you. So, good morning, everyone. Thank you for joining us. And today we have two consecutive TAVR cases for a live demonstration from Asa Medical Center. So we're going to start our first cases. Anyway, before that, Dr. Hong, large markers, my old friends, is really thank you for joining us, and many distinguished panelists, Dr. Kao, long time no see, so it's really hard time for us. Dr. Rafael, Santoso, Wong, Dr. Yu, really thank you for joining us. And Jongmin actually his main operators, lots of experience of TAVR cases, and fellow Dr. Bach and so many colleagues getting together, right? So we're gonna start the first case.
Yes.
Okay.
Yes, I'm Jinsun Park from Asa Medical Center. This patient is an 80-year-old male. He was admitted for exertional dyspnea with the NIHA functional class 2. He has a history of atrial fibrillation, and the echocardiography showed severe rheumatic ASR with mild LV dysfunction. Next. And he has several risk factors that are diabetes and hypertension, and his STS score is quite low, 1.7%, and his clinical presentation is exertional dyspnea. Next. And the echocardiography shows he has mild LV dysfunction, and Vmax of aortic valve is elevated to 4.8, and mean pressure gradient is also elevated to 57 millimeter of mercury, and his aortic valve area is 0.69. Next. And this is the CT findings of this patient. In this aortic annulus view, if you can see that this table, his short diameter is 23.3 and long diameter is 31.8. And annulus area is 603.5 and perimeter is 88.9 millimeter. Next. And then this is a sinus of Valsalva and ST junction. Sinus to annulus area ratio is 1.27, is quite smaller than mean value. And ST junction to annulus area ratio is 1.4. Next. And then this is the LVOT, and there are no visible calcified region in LVOT. Next. And we also analyze the amount of calcium. The total calcium volume of this patient is 503, so it's a quite large amount. So we plan to pre-ballooning before valve implantation. Next. And this is a longitudinal analysis of calcification in aortic valve. Next. And his coronary height is more than 12, so it's quite enough for TAVR. Next. And then this patient has large peripheral vessel size, so it is large enough to transfemoral approach. Next. And this is a sizing table for SAPIEN 3. We plan to perform TAVR using SAPIEN 3, 29 nominal size to getting 107 area size oversize. Next.
Okay, right. Right, the case is relatively low STS scores. However, echocardiographic findings that suggest that cardiorheumatic, origin of valve destructions, and AS, AR, severe AR components, right? And you have already, see that the CT algorithm, right? Our own algorithm. So would you show us again? And so, Dr. Hong, Rajesh, would you discuss about?
I think so. As Jay, this is an excellent case, right? I think clinically it is very appropriate. This patient has some symptoms, but you can see that the ejection fraction has gone down, right? I think you would normally expect the EF to be high, not low, especially even more so when you have some aortic regurgitation. So clearly the LV function is now getting affected. There is atrial fibrillation as well. So even if there was no symptoms, one could make an argument to actually intervene, and there are some symptoms here. So, and I think in the anatomy that you presented, the access is excellent. The aortic angulation is excellent. The coronary height is very good and favorable. And, I think the calcium seems to be distributed across all three leaflets. So I think that when you look at the salient features of this case, as you presented, this seems to be an excellent case clinically as well as anatomically.
Right.
Yeah, I think that there is some issue. The mild LV dysfunction caused by the aortic valve stenosis or regurgitation itself, or is there any other cause for the mildly decreased LV function? And second one is that the etiology was done by the rheumatic, not the degenerative. It means there is the involvement of the rheumatic disease in the another valve for the mitral valve or the others.
Yeah.
Other valves are okay.
All right. So any, expertise point of view, any concern about the rheumatic origin of valve disruptions rather than the degenerative ones? Okay.
I don't think so. I think you have enough calcium. So irrespective of what the etiology is, rheumatic or not, and even in patients with rheumatic heart disease, where there may not be a lot of calcium, I think, if you appropriately oversize it, you should be okay. So I per se do not see any technical challenges, in doing this case with TAVR.
Yeah, I think I totally agree with the indication on this case. Procedure-wise, would you do a wire pacing for this patient, or do you usually set up a temporary pacer?
Yes, we are using, usually we are using the temporary pacemaker.
Okay.
Yeah.
Because for this case, I think a wire pacing maybe is enough.
Okay, we didn't show the current status. Just look the irritable situation. All right. Second one is right. We actually personally, I prefer the Sapien 3 expandable, TAVR devices. However, what do you think in terms of a choice of a device in self-expanding, balloon expandable for a particular use case?
Well, I'll let some of the panelists also chime in, but while they are gathering their thoughts, I think that this is a good case for either device. And I think it's good for Sapien 3 platform, and I think it's also an excellent case for multiple other platforms. I think that you can also use Evolut. It is probably a little too large for the accurate device, but I think that you could make an argument here to use either one of these devices. This patient is 80 years old. From what I can see here, there doesn't seem to be any significant coronary artery obstruction. So I think that coronary access is less of an issue, especially in somebody who is 80 years old and doesn't have, coronary stenosis. But I think so that you should do something. You should choose a device that you're most comfortable with and do a lot of. So at my center, we would actually go ahead and use a SAPIEN 3 valve, but I think other choices are excellent as well.
Yeah, and also in addition, the access size, the vessel size is big enough. So I think this case is suitable for almost any available devices.
When it comes to oversizing index, you selected the 29 millimeter SAPIEN 3 valve, and then the nominal pressure, the oversizing index is 75%. I think that the valve, the calcium limited between the two leaflets. So I think that the 10 or 15% of oversizing index is optimal for this valve. What do you think about that?
Raphael, so Dr. Raphael, what do you think?
Well, I certainly agree with all the comments, and with Raj, this would be a case suitable for a balloon expandable or an expandable valve. In fact, we've just did our first 2 cases of the Accurate XL, which is the sort of equivalent 29 millimeter valve. And as mentioned, the femorals as well is of a good size, so you can pick any valve you want to. In our center, we're primarily as Edwards side, so we would, as you have chosen, SJ, would use Edwards SAPIEN 29. My one query obviously is we avoid pre-dilatation with SAPIENs these days unless it's heavily calcified. And I just want your comment. He's already got a bit of aortic regurgitation, so are you still considering balloon valvuloplasty? And if so, obviously we could make that aortic regurgitation a bit worse. So if we're doing that, I think we have to be ready to go ahead with the valve quickly in case you make that AR worse. But otherwise, I agree, a good, excellent choice of a patient and a good indication.
What about the Tegu?
Yes, I completely agree that we can choose either self-expandable or balloon expandable valve. And if I'm in your position, I would do the case without the balloon pre-deal.
Yeah.
All right.
I would agree. I think that I would skip. We tend to predilate only in patients who have very heavily calcified valves, where the valve is really tight or the aorta is horizontal or in heavily calcified bicuspids. And I think, as Owen mentioned here, I think pre-existing AR even makes it more attractive not to predilate.
Would you show us again CT, size selection? So, all right, great. 29. All right, so Dr. Anzu will discuss is, you choose a SAPIEN, right?
Yeah.
A balloon expandable. And in terms of area of sizing, devices, size selections, would you discuss that one?
Okay, I fully agree with Dr. Yu's suggestion. Dr. Yu commented that the 29 nominal size only 7.5% oversizing. So he suggested that the 10 to 15% oversizing would be better than 7.5 because calcification is not so severe. Calcification located in the evenly distributed in the 3 leaflets. So yeah, so we changed our mind to we added the 2 cc more into the balloon. So we like to make 15%, around the 15% oversizing for this patient. So in addition, I agree with Dr. Raphael's suggestion that we will go direct implantation without pre-balloon valvuloplasty.
Razi, what do you think in terms of size-wise, the area of size?
29 with a couple of extra cc's available, and then I think some operators will actually connect with a stopcock to the pressure gauge. We don't do that, but I think when we are using, because with the 29 inflation device, there's no pressure gauge. And I think it's reasonable. People who use that will normally not exceed 6 atmospheres the first time they actually inflate it, but I think two extra cc's available, and then you see how you feel it. So if you need to leave a cc behind, that's okay, and I think that's the way we do it. And also the LVOT was a little bit larger here. A lot of times if the annulus is okay and the LVOT is a little bit smaller, you can actually get sealing there. So I think given that, it's very reasonable to have 2 extra cc's in this case.
Great. So finally we decide, 29 nominal and 2 cessable field, very, delicate, accommodation in terms of inflation volume, something like that we can match. And so after the CT algorithm anyways, and based on our experience, is a very high, success rate immediate after, procedure related any complication. And so pre-dilation and, we'll do or not, actually we have, criteria. So what would you? What
Actually, we decide to the direct stent based on our classification, patient median classification volume. Our center median classification volume is around 400. This patient 500, so higher than our criteria for the direct implantation. But considering the very severe AR and some concern about the acute complication for valvular balloon dilatation, so we will go the direct stenting, direct implantation.
Anyway, so today is a special day.
Yeah.
So you want to do the all right, direct device implantation. And so okay, would you let's start that one?
Yeah.
Okay, finally, maybe 2 cessable field, meaning is 12%, area of sizing.
Yeah.
So I think so. So a little bit bigger. And if you see the annulus long diameters by CT findings, actually it's almost more than 30. And so I'm not too much concerned about any. All right, 29.
Yeah. So what wire do you have in the LVSJ?
Safari wire.
All right,
Safari
Safari.
Okay.
All right, all right. And then, so would you explain?
Yes.
Okay, it's more.
We pull the
Safari
the-
yes or small?
small.
Small, okay.
Pull back the balloon delivery system into the stem, and there's more fine, manipulations to stand on the balloon itself and just a proximal dot. And again, fine tuning again, exactly the place, same place, okay,
Just a moment.
it's okay. Great. So it's not.
Did you unlock the system and relock it, or do you like to just go? Either one is fine. So I think some people
full
unlock and relock so that there is less tension if they're going through a tortuous. But this is fairly straightforward.
Give it a show. Yeah. Okay, test contrast, please.
Test.
Okay, and then check down. You will really do the pushback.
들어간 다음에 되겠습니다. 아직
Okay, all right. It's still we are on the. Okay, not too much difficult to pass this. Test, please. Okay. Anyway, we are gonna do the little bit more fine accommodations place of the device. So push out up to the second dot or third dot. Okay. And then I really want to do still coaxials. Jump. One more thing, please. Great. Test. Position wise, actually, I matched with the central dot with the Johnston all those areas, and especially for if you look, you can see that the proximal distal part of stent is a little bit of position, and then it is 29. It's a big device that had some trend of sudden step up and pop up the device itself. And so I agree for the safety concern, central dot would be sinus level. Is quite test, please.
Test.
What do you think?
Good.
So
I
pigtail.
think that ICC a little bit cranial. So
This is the deployment angle.
This is coaxial
Yes,
view.
this is
It's okay.
coaxial view.
Yeah.
All
Do you-
right.
Are you planning to come back up a little bit higher, or are you planning to be there?
Oh no, it's okay. I think it's okay. Test, please.
Test.
많이 주세요. Okay. What is
Oh.
too much? So
Down.
just push the wire. Okay. Use that one. I think it's okay. Test again. No. Here we are. Early tester.
Test.
What do you think?
Okay.
Okay.
Should be okay.
Yeah.
Yeah, right. Exactly.
Yeah, I think that's reasonable.
Facing. All right. Okay, why
Inflation.
not? All right. Inflate. Push
One,
in. Okay, good.
3.
4,
Great.
5. Okay. Inflate. Facing up, please.
All right.
Okay, that I adjust, prevent pull back and pull back in and adjust, just to fix the device itself. But during the inflation, that is only my role.
Did you empty the whole volume?
Yes.
Okay, so this was plus 2.
It takes us some time because
29, usually, okay.
The angle, so you can remove the parallax. I
Take
think
a picture first.
Good, good.
I think it's good.
Yeah.
Right? 29, maybe PBLs along the wire itself. The central type is not much. What do you think?
So SJ, can you remove the parallax so the device looks like a rectangle?
Mhm.
Then what you can do is see if the pigtail catheter will go down. If there is room, if you counterclock your pigtail catheter and see if it will go down in the cusp, you might,
Okay.
And yeah.
Then
Can we also see the hemodynamics?
Yes.
Just to get some
Oh,
idea
you're
of
gonna-
the severity of the AR.
okay, we're gonna show you.
I mean,
After the one more.
diastolic pressure went up from 35 to 55 briefly. There was one shot we saw that, but I think.
Okay, I will take the picture again.
Yes.
Hold those.
Okay.
Still some,
So the question is, we don't know whether this is paravalvular or whether this is.
all right. Since we can do the echo, we can do that.
You can exchange a pigtail over the Safari wire.
Yes.
That would take some of the wire bias away.
Yes.
Right.
And also you can measure the hemodynamic and calculate the AI index.
Yes. So I think that will be the right. I agree with Dr.
Yeah, diastolic, aortic pressure is good.
But at least the initial diastolic pressure is around 30 or 40. But after implantation, diastolic pressure is 61. So in addition,
And all right, size-wise, we need okay, so we can do a little bit more, 160 or 260 or something like that. However, we're gonna see that what's happening there.
actually, this is a severe power leakage.
Great.
But
cross-section 잘 졌네 우리. Good. Echo cutting. Find it.
칼라 좀 넣어주세요.
Do you expect that the LV dysfunction will be improved after the TAVI procedure?
Yes, I hope so. So
Yeah.
among 30%, 40%. I don't know.
48.
Yeah.
48.
All right. The patient group who had a low ejection fraction is getting improved after the TAVR procedure. We believe that this 48% is maybe getting better.
And
Okay.
the next plan after the successful TAVI procedure, in this patient have the atrial fibrillation. What is the recommendation for the pharmacological treatment? Antithrombotic and the antiplatelet agent.
No
What is the
deficient
plan,
and no
pharmacological plan?
Mainly,
no aortic regurgitation and no definite effusion.
all right. So, we're
Good,
gonna
good,
move.
good.
Anyways, I'm gonna move the device and show you the pressure, simultaneous pressure monitoring. Maybe we can measure the AR index too. All right, great. Picture,
Okay.
잠깐만.
Dr. Park?
Yep.
Yeah, can you tell us your closure strategy now? Still two-stitch ProGlide or a hybrid? What kind of a closure?
Two ProGlide.
Two ProGlide.
29 to 42 for ProGlide.
Two ProGlide. Okay.
In our lab, currently we only use the one
Great.
ProGlide.
지금 게 좋은데?
Yeah.
And then if there is something wrong, we will introduce another one. So
Okay.
optionally.
In our lab,
Did you see the pressure
Yeah,
monitoring?
yeah. It looks perfect.
Yes.
Yeah.
All right. Looks perfect. It's perfect.
Uh,
I
like
bet
this
that
one, right?
I bet that
Alright.
if you take an aortic shot now, there will be less AR.
Yeah.
I think that's the
Please.
wire bias.
Yeah.
please.
Even in the AR index is perfect, and so I'd like to pull back the LV wire. I think it's okay. And we're gonna show the aortogram again. Finally, All right.
I'd like to one comment about that the aortic regurgitation. The echocardiographic finding is a no regurgitation, and hemodynamically is a perfect.
Mhm.
So it should be the correspond to the angiography appearance. So it is a very interesting. What appearance in the final angiogram?
all right, I will show you.
Yes,
After-
please.
after we will-
Very interesting.
You know, in the LV wires, so we are not sure about that. Oh well, I think it's very trivial
Yeah, true.
PBL. We're gonna do 1 cis or 2 cis more, you know, overfill the balloon inflation. However, I think it's quite enough. As you've seen, you know, perfect hemodynamics, and maybe the PBL, this kind of a trivial PBL is getting better, as you know, during the follow-up period. So, it's okay. So,
okay.
Yeah,
any
I
comment?
agree. It's a nice result, and most of that AR we saw earlier, as the panel have suggested, was probably related to the stiff safari wire, which
Right,
often does that.
Great. Dr.
Also,
Wong?
I think he's 80 years old. That's not very old, but old. And I think that if you have pre-existing AR, you know, residual AR is, you know, much better tolerated. So I think given those hemodynamics were reassuring. So I think you've taken everything out. So I think it's it's reasonable to.
80, even 80s, he's very, you know, strong, still young, look young. All right, so maybe, okay, so what is any comments? We're gonna move second cases, okay?
Great cases.
All
It's
right.
excellent result.
Okay.
Thank
We
you.
will move to the next cases.
All right, I really,
Thank you.
all right, great to see you all.
Great,
Okay, can you
Thank
hear
you.
us?
great case.
Yes, sir.
Okay,
DW Bob,
okay, thank you
Okay.
for
Get well
joining.
soon. Get well soon.
please.
Okay, thank
Please,
you. Thank you
go
for
ahead.
joining our TCTAP 2022. And I'm very happy to invite the moderator, MK Hong and Raj, and the panelists, is Paul and Owen and the Tevku Santoso and Dr. Ong and Dr. Wu. So I'm sure absolutely our case is much complex and much interesting case rather than first case. So my name is DW Park from Assam Medical Center, and the Do Yung Gang, the junior faculty, our TAVR specialist fellow, Dr. Kosadi from Saudi Arabia. Okay, Dr. Gang, can you present patient background?
Yes, the patient is an 81-year-old female who admitted for exertional dyspnea. She underwent TAVR, transaortic TAVR in 2017 with Sapien 3 23mm valve. And despite after the TAVI and then after 2 years and 3 years, the transaortic velocity pressure gradient is simultaneously increasing. And after the use of the anticoagulant, even the bioprosthetic aortic valve stenosis was progressed. Echocardiogram showed severe bioprosthetic aortic valve stenosis due to degenerative change. She had a history of atrial fibrillation and underwent PCI 5 years ago. Next. And her SS score for mortality was 3.1. And next. And the echo showed normal ejection fraction and the peak transaortic velocity 4.8 meter per second. And her peak and mean pressure gradient was 91 and 56. Next. And this is the aortic valve Vmax. Just after the TAVI, the Vmax was 3.0. And after 5 years, it was increased up to 4.8. Next. And CT showed the valve degeneration with opening reduction and leaflet and subvalvular soft tissue thickening, and also hypoattenuating leaflet thickening at the right side cusp of the TAVI valve was shown. Next. So first we suspected the valve thrombosis, but even after 6 months of the anticoagulation with the warfarin with the appropriate INR, it did not change. Next. Next. And we checked the current status of the valve, and the valve inner mean diameter was 19.5 millimeter with the inner area 300 square millimeter. Next. And also you can see the leaflet with the thickening. Next. And LVOT area, there is no severe calcification at the landing zone. Next. And next. And you can clearly see the shape of the valve. Next. And the coronary height is when measured from the base of the previous Sapien valve, it was sufficiently high, and there is the good opening from the coronary opening from the previous Sapien valve. Next. And iliofemoral access was okay. Next. So this is the sizing chart for the current status of the valve, and because the previous valve size is very small and the lumen area of the aortic valve is so small, so we selected the Evolut system to gather the larger trans valve area. Next. Yes. And this is our plan for the valve-in-valve procedure. We decided to implant the Evolut Pro with a 23 millimeter, and we decided to perform predilation to maximize the valve area.
So, and if I'm gonna summarize this patient, 82-year-old female, and we implanted 5 years ago, 2017, Sapien 323. Patient is going well for 3 years, but nearly 7 months ago, patient complained the new onset dyspnea. At the time, from the 6 months, it's going up the Vmax, and by echocardiography, mean pressure gradient is going up. So at the last 6 months in our heart team, we have a 2 and 3 times discussion how to treat this patient. Initially, our imaging specialist at the time, we checked transesophageal echo. Our echo specialist proposed the leaflet thrombosis, the first suspected, second valve degeneration is suspected. Our imaging, the specialist, the CT specialist proposed a leaflet thrombosis, the first suspected, and the second valve degeneration. So last 6 months, we are keep the NUAC 3 months, and then we changed the warfarin. We try to keep the PT-INR nearly 3.5 in the last 3 months, but last 6 months and the patient dyspnea is aggravated. Also, serial echocardiographic follow-up showing the Vmax and mean pressure gradient is going up. We finally decide to re-intervention for this TAVR valve, the failure. So at this moment, would you like to share some comment and any question for this patient?
I have a question. What was the antithrombotic regimen before the warfarin therapy for this patient?
Yes, we tried
AP, that coronary stenting, very complex underlying comorbidity.
We keep the rivaroxaban plus aspirin. And absolutely. And
DW.
Okay.
DW.
Yes.
May I comment?
Of course, sure.
Okay, sure.
From the image, the valve size, the previous Sapien looks adequate, but it's quite strange because right after the first implantation, the lowest velocity you can get is still 3 meters per second. So is this some sort of PPM? Is the valve slightly undersized for this patient?
Yeah, at that time, we tried to implant nearly 10% oversizing, although and Vmax is slightly higher, 3.0, and the maintenance and the 3 and 4 years. But this event was occurred nearly 1 year ago. And for after initial implantation, patient is no complaint of dyspnea, and just the complaint that dyspnea is 1 year ago. Yes.
Yeah, because in our experience, right after implantation, a velocity of 3 meters is somewhat high. That's my first comment. And secondly, is that this patient had a PCI history. So if you are going to implant a supravalvular device, maybe you want to check the coronary patency before you do so, because otherwise engagement would be a bit difficult in the future.
Yeah, absolutely.
Let me ask the patient status. What is the body weight and the height? What I mean is that because maybe the small stature of the patient, therefore you deploy the small size of the Sapien, only 23. So what is the body weight and height? And the second one is what is the aortic valve area before the TAVI procedure in the 5 years? And then what is the aortic valve area immediately after the TAVI procedure, first TAVI?
The body weight and
the body weight is very large. So she has a body weight of over 60 kilograms, and the height is short. So her BSA is small, but she's a little bit obese woman. So I do not remember the exact number, but she looks like the 160, less than 160 centimeter, but body weight is more than 60 kilograms.
Yeah,
the reason why this kind of the patient is common in the Asia, particularly in the elderly female. So only we use the small size of the valve. At the time, we try to achieve a more larger valve area. So the only Sapien 23, maybe I expect that the valve area after the TAVI is 1.2, 1.3, that's it. So in current status, if you deploy another valve, I'm sure technically perfect, but another 5 years later, what is the future in this patient after the second TAVI?
Yes. So absolutely, I 100% agree, and really, and in special Asian population and the PPM issue and the prosthesis patient mismatch, we don't know how to impact the PPM, the influence the long-term TAVR durability. And so, however, we should be still concerned for this patient, we are discuss our heart team. If you decide to the additional sapien, we should choose the sapien 20. And that absolutely PPM issue concern. So reason why we select Evolut system 23, and the supraannular structure would be much better for to maintain the much bigger size of aortic valve area.
I think this is a fascinating case, right? And it's the discussion points that have come up are all very appropriate. So the data would suggest, right, whatever data is available would suggest that whether you do SAPIEN in SAPIEN or whether you do a Evolut in SAPIEN, you should get good acute results. I think what we know is that the results are, you have to be very careful doing an Evolut in Evolut. You know, that's where you have serious issues in terms of coronary access. So I think you could make the argument both ways, right? You could say, okay, let me go ahead and use a SAPIEN valve again this time and see if it'll last for another 5 years. And then the third time around, I will use because coronary access won't be an issue with the SAPIEN. And I think you can, in fact, even put it a little bit, tiny bit lower, you know what I'm saying? So you could try and do that. But I think it's also reasonable to say that let's use, this is a valve that degenerated in 5 years, and maybe we'll have better luck with a different design with the supraannular valve. You know, and coronary access will be a little bit of an issue, but I think these are the pros and cons. I think the good thing is that the left main is coming just, it seems like just above, you know, where the leaflets are, and maybe just at the level and somewhat above the level of the frame. And the right coronary artery was high enough. So I think it's an open question. There are pros and cons.
Coronary angio 한번
Yeah.
Okay, we're going to show us coronary angio and okay, DIR initial. So we checked that this is the right coronary diminutive artery, and this is left coronary absolutely above the upper cell, and we can avoid and to overlap the TAVR valve strut. And next one. So and this is the coronary access, and the next one. So and this is root angio. We can see there is no the AR jet, absolutely how much tight this one. And next one. So wiring is sometimes the very difficult to the TAVR valve. Sometimes surgical valve cases take sometimes 30 minutes. And this luckily the past we used the AL1, and we used the pattern was failed, and we choose the more steeper the ring torque wire, and the path easily finally faster it more faster. Okay, got it. So and we put the dual monitoring of aortic valve. Can you see the monitor how much different pressure curve? Okay, as you can see, we can see there is a big pressure gradient, and so at this moment we absolutely our heart team decide to put the Evolut 23. So at this moment in technical point, and we have some two debatable points. One is how do you do whether or not do pre-dilation for TAVR failure case, and second one, how can you match the implantation depth would be some issue for such patients. So, and we are experiencing many cases surgical valve failure and then TAVR implantation, usually very straightforward, and TAVR is a much complex case. So we're gonna do the pre-dilation for full expansion. Also, sometimes the valve failure case device passage is very difficult, and we're gonna do a pre-dilation using 18. Yeah, okay. And then
selection for the Evolut system, you will have a plan to use the Evolut 23. Actually, 23 is too small.
So could you show the sizing chart, and you know the 23 and the area could you show PPT part? And this is the sizing chart. And if you're going to select 26, there was a too much oversizing, 76% oversizing. So if you put the too much big size, there was some concern about the, Rajmark reported paper. We also experienced the same case, the sinus sequestration case. Although the technically is good, but we concerned about coronary access. So
Is it based on the native aortic
Okay.
valve or the
okay.
valve-in-valve cases?
Okay.
I-
You got it.
Even though this is a 23, right? I think it would be interesting. I don't think the diameter was 23 when they did the CT,
Okay. 준비됐어? 자, 테스트. Okay. This
From
is
CT, it was
18.
only 19.
자,
From
천천히,
CT, it was
천천히.
only
I think
19.
it is,
자,
I
patient
think
on.
it is reasonable.
자,
Now,
inflict.
when we do these, we
Okay,
don't
inflict. 안 벌어졌지?
don't tend
Patient
to
off. Okay,
facilitation.
one more again.
I'm
From the
curious
upward.
because all these
Okay.
bioprosthetic leaflets
자, 다시.
concern I always
patient
have
on.
pre-dilate.
Inflict.
MLIs.
그렇지. 풀. Deflect. Okay, patient off. Okay, and then we're gonna put the
Yeah, I
Double
agree with you,
system.
Raj. That's been our concern as well in pre-dilating these bioprosthetics.
빠지면 큰일 난다.
And often you can post-dilate once your valve-in-valve goes in,
1, 2, 3, 1, 2, 3.
which is probably safer from the
Okay.
embolic aspect of it.
So after pre-dilation, I'm gonna put the evolute, the 23. So at this moment, how much deep the rod in the prefer, and our targeting is we try to match a lower margin of evolute system to same line in the previous sapien valve. So previous, okay.
Well, may I ask you, panelists as well as Makar, in this kind of degenerative valve procedure, would you do neuroprotection?
I think the true answer is we don't know, but I think it would be reasonable.
Great curvature. 3시 방향 맞췄지?
Reasonable, I think.
Okay. The port is 3 o'clock.
I think it would be.
Okay. Okay.
Very nice.
오케이, 자, 한번 맞춰보시죠. 지금 하고 코플라나비에. 오케이. So I try it over here. 한번 들어가서. 자, 여기서 한번 살짝 쏘봐. 오케이, 릴리스. 오케이, 천천히 릴리스. 자, 여기서 한번 120 pacing.
Yeah, I would try not to be higher because you want to have your coronary
혈압
access
떨어지면 얘기해 주세요. 릴리스. 자, 천천히.
slightly lower.
천천히.
But I think this is good.
천천히.
Yeah, that looks good.
자, 120 하고 있지? 오케이, 릴리스.
Are you taking care of the commissural alignment during deployment?
자, 올려, 쭉 올려.
Yes, I think so. He did it.
조금 더 올려, 더. 자, 프레셔, 더 올려. 혈압 나올 때까지. 자, 조금 더 됐어. 오케이. I think slightly deeper.
Yeah, I think you're slightly deeper.
Yeah,
a bit deep.
야, 혈압 괜찮지? 아직 잠깐만. 자, 여기서 혈압 보여주세요. 자, 페이싱 오프. 다시 감아. 다시 감자. 반대로. 감아. Okay, I would like to reposition again.
A bit too deep, and the head marker is outside, but it's
Okay.
Okay.
끝까지.
Yeah.
Okay, more. 완전히 끝까지. 오케이, 됐지? 자, 아무 얘기하지 말고 내 말 들어. 자, 준비됐죠? 자, 120. 자, 페이싱 오프. 자, 릴리스. 천천히 릴리스. 혈압 떨어질 때 얘기해줘. 자, 천천히 릴리스. 잠깐만. 아직 지금 밑에 게 아직 안 나왔지?
You're high.
Yeah, you're out.
자, 오케이. 자, 오케이. 릴리스. 120. 자, 릴리스. 천천히. 릴리스. 오케이, 릴리스. 자, 릴리스. release, 천천히, release,
release,
okay, release, 천천히 여기서 천천히 기다려. 자, release, okay, release,
release,
okay, release,
release,
자, 쭉 올려, release, release, release,
This is good.
release, release,
That's okay.
more release, release, 더 release 하자. 조금 더 release 하자.
I think it's so far so good.
Yes.
Technically, it's reasonable and acceptable.
조금만 더 감아도 돼. 자, 조금 더 감아도 돼.
감아요.
저 풀어. release, that's okay. 기다려봐.
혈압 좋고요.
오케이, 혈압 괜찮지? 오케이, 테스트.
And when you release it, it will tilt on the other side, on the left.
오케이, 자 한번 풀어보자. 지금 괜찮은 것 같아. 자, release, tension release, tension relief, 다 풀어.
Go up
Yeah,
higher.
release.
오케이, tension relief, full. 오케이, tension relief. 오케이, tension relief. 다 풀었지? 더 풀어.
release,
끝까지. 오케이.
Excellent.
오케이. 자, 다 됐죠? 자, 조금 더 풀어. 오케이, got it. Okay, slightly pull back over here. And then absolutely be careful.
Yeah, nice position.
curve. 오케이.
등 하나 빼고
오케이, 좀 풀고.
거기서
자, 여기서 한번
회색을
찍고.
당기시면
자, 이렇게 놓고.
회색을 당기십니다.
요거, 뒤에 걸.
이렇게
자,
누르고 오케이,
네,
keeping the
됐어.
wire. 오케이.
오케이. 자, 여기서 한번 테스트 한번 해보시죠.
네.
오케이,
준비됐고요.
테스트. 자, 여기 한번 찍어보자.
네, 찍겠습니다.
Okay. Shot. Okay, the coronary, I think it's good. And the
coronary
remove,
is good.
I'm gonna check the monitoring again, simultaneous. 자, 보면서.
Yep.
1, 2, 3. 잠깐만, 다 뺐지?
네.
1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. 1, 2, 3. Okay, and pick 10. So I think that would be okay.
I think this is a good position. I
Yes.
would look at the gradients and then have a
Mhm.
low threshold to post dilate if necessary.
Yeah.
Okay. So we can use a much bigger size, but it's recently we experienced some sinus sequestration cases that was very catastrophic. 자, 요거 하고 요거 자. Okay, you're gonna show us. We will show the monitoring. 됐나? Okay. That's it. Okay. I think the hemodynamics looks fine, and there is no pressure gradient, and the AR index nearly the 40-50, and I think it's a much improved than before procedure. So I'm gonna finally check the angel. Okay. 이렇게 놓고.
바꿔주시면 됩니다, 선생님.
So, and absolutely, the many physician is concerned. How do we keep the anti-thrombotic strategy for such valve-in-valve case? And although this patient is AP patient, we absolutely requiring the oral anticoagulation test. Okay, and you're ready? 갑니다. 자, 풀샷. Okay, I think coronary is good. RA view.
Good.
Yeah,
Good.
I think
Excellent.
this is, I think the hemodynamics are excellent here. You've preserved at least coronary flow, and I think when I look at it, I think it should
Okay, previous one.
not be that hard to access the coronary because,
Yeah. So I think this is a very educational case, and we are nowadays some experience of TAVR valve case, and next step is how can you do and the surgical explant TAVR valve or TAP in TAVR and which type, how can you do anticoagulation, antithrombotic, that would be some further issue. And Raj, you experience a lot of complex case, and your some comment and suggestion would be very helpful to the audience. Yeah.
I think that, we would go ahead and put this patient on anticoagulation, despite the fact that there was a failure of anticoagulation the first time around. I think I would switch things around. If the patient was on warfarin, maybe I would try DOACs, and vice versa. I think that it is reasonable in this case. And I think that this patient is an AFib, right? Am I correct?
Yes. Right.
So I think we have enough, we have the recent trial with the doxaban, which favors using that, or you can go ahead and use warfarin if that was not the case first time around. And I think I would monitor the gradients of this patient. I might even, this is an absence of any data, right? But I think we are treating, this is precision individualized medicine for this particular patient. So I think I would do that. Typically when we do these cases, I'm always curious, and before I finish the case, I'll try to access the coronary arteries just to see what I will be up against in the future. You know what I'm saying? So I think that would be another interesting thing to do, just to, because we are all curious right now, right, to see how these patients will be in terms of coronary access. Yeah. So I think those are the only things, and I think I'll keep a close eye on the gradients every couple, do echo at 30 days and maybe a couple of months at least for the first few times.
Any question or comment? And MK Hong?
Yeah, I certainly agree, Raj. This is, we don't have a lot of evidence, and so this is individualized best clinical practice for this particular patient. And like you, I would certainly give this patient the best anticoagulation we have available, and for us we've just got the standard DOACs, and I'd certainly be considering at least 3 months of warfarin, which we know, if you keep your INRs well, works extremely well. You don't want this valve to fail. It is a surprise that the first SAPIEN did fail. Yeah. And we've got plenty of 23s and they don't fail. And in the absence of severe renal impairment or dialysis, it is unusual. But I certainly agree. I think good anticoagulation and close monitoring.
Great.
I completely agree, because we have some concern about leaflet thrombosis in the past, and also the patient has a chronic atrial fib. So I would incline to switch the anticoagulation therapy from warfarin to NOAC. And with NOAC, considering the age of the patients, we know that bleeding is an important concern also. Probably aside of rivaroxaban, Eliquis is also a good choice, because we know that there are some data showing that with Eliquis we have less of bleeding problem.
Well, I concur with the comments on the antithrombotics. Still, I'm concerned about the pressure gradient, because DW, at the end of the procedure, you did show us simultaneous recording, but from my side, I still appreciate some difference between the left ventricle and the aorta. So I think in this particular patient, maybe we should really consider a mismatch. And I would like to achieve 0 gradient between the 2 chambers. And I will, of course, follow up them very carefully with the echo to see any rise of the flow velocity.
Great. Okay.
So overall, I think is that this case is the very excellent. Procedure is excellent, and the meaning is that they are very educational. The excellent procedure. I'd like to say congratulations.
Thank you. Yes. Thank you.
Yeah, DW.
Congratulations.
Thank you.
Congratulated.
Thank you.
It's a great job.
Thank you.
Thank you.
Absolutely.
That's good work.
Okay. Dr. Makar, please close comment for this session.
Sure. So I think we all enjoyed the demonstration of 2 excellent cases, right? The first one was with the balloon expandable technology in what we would call a bread and butter aortic stenosis with excellent indications. The patient was 80 years old, had excellent anatomy, very favorable anatomy, and we got a good result. And it was done with conscious sedation, and I think the procedure went very smooth, right? I think, that's very expected with what happens in the cath lab these days. And then DK actually showed a case which we may start to see more frequently as we, fortunately so far, the incidence of valve degeneration has been very low. I think earlier on it was low because we were doing TAVRs in older patients, but as we start to do this in younger patients and they live longer, and as we start to see patients back in the clinic that have had TAVRs done 8 years ago and 7 years ago, I think we will deal with this more frequently, the issue of valve degeneration. And what we saw was dealing with a balloon expandable failure using a self-expanding technology. And I think once again, I think the hemodynamics were quite acceptable. And I think one could argue whether we should have done further post-dilatation. And I think some important issues were brought up regarding anticoagulation. So I think two excellent cases of, two different technologies in two different clinical situations.
Thank you.
Okay, terrific.
Thank you.
Thank you
Thank
very
you.
much.
Yeah.